Myocarditis. Myocarditis is an inflammatory disease of cardiac muscle. It can be acute, subacute, or chronic, and there may be either focal or diffuse involvement of the myocardium. Etiology. Incidence. The true incidence of myocarditis is unknown because the majority of cases are asymptomatic. Involvement of the myocardium has been reported in 1 to 5% of patients with acute viral infections. Autopsy studies have revealed varying estimates of the incidence of myocarditis. A 5% prevalence of active myocarditis was reported in a high-risk group of 186 sudden, unexpected medical deaths in children. Risk factors. Certain groups appear to be at increased risk of virus-induced myocarditis, and the course may be hyperacute. Young males, pregnant women, children, particularly neonates, immunocompromised patients, HIV. Pathogenesis. Both direct viral-induced myocyte damage and post-viral immune inflammatory reactions contribute to myocyte damage and necrosis. Inflammatory lesions and the necrotic process may persist for months, although the viruses only replicate in the heart for at most 2 or 3 weeks after infection. Evidence from experimental models has incriminated cytokines such as interleukin-1 and TNF. Oxygen-free radicals and microvascular changes as contributory pathogenic factors. Clinical manifestations. The clinical presentation of myocarditis is variable. Most cases are subclinical. However, at the other end of the spectrum, myocarditis may be the cause of unexpected sudden death, presumably due to ventricular tachycardia or fibrillation. A variety of cardiac symptoms can be induced by myocarditis. Chest pain may occur, usually due to concomitant pericarditis. Excessive fatigue or decreased exercise ability may be the initial sign of myocardial dysfunction. Since both ventricles are generally involved, patients develop biventricular failure. Patients present with signs of right ventricular failure such as increased JVP, hepatomegaly, and peripheral edema. If there is predominant left ventricular involvement, the patient may present with the symptoms of pulmonary congestion, dyspnea, orthopnea, rales, and, in severe cases, acute pulmonary edema. Physical examination. In addition to the signs of fluid overload, the physical examination often reveals direct evidence of cardiac dysfunction in symptomatic patients. S3 and S4 gallops are important signs of impaired ventricular function. If the right or left ventricular dilatation is severe, auscultation may reveal murmurs of functional mitral or tricuspid insufficiency. A pericardial friction rub and diffusion may become evident in patients with myopericarditis. Laboratory findings. 80 patients with clinically suspected myocarditis were screened for CK activity, CKMB and CTNT. Endomyocardial biopsy specimens were examined histologically and immunohistologically. CTNT was elevated in 28 patients, CK in 4 and CKMB in 1. Immunohistologic analysis revealed evidence of myocarditis in 93% of 28 patients with elevated CTNT levels and in 44% of 52 patients with normal CTNT. Mean CTNT levels in patients with myocarditis were 0.59 +/1.68. Cardiac troponin T in patients with clinically suspected myocarditis. J.M. Col Cardiol 1997 November 1 35, 1354-9, Viral titers electrocardiogram chest radiograph. Acute and convalescent antibody titers may indicate an active or recent viral infection. They do not necessarily indicate the etiology of the cardiac abnormalities. Electrocardiogram may be normal or abnormal in myocarditis. However, the abnormalities are non-specific unless there is pericardial involvement. The changes that may be seen include non-specific SAINT abnormalities, atrial or ventricular ectopic beats, high-grade ventricular arrhythmias, atrial tachycardia or atrial fibrillation. Chest radiograph ranges from normal to cardiomegaly with or without pulmonary congestion. Magnetic resonance imaging. Echocardiography. Most valuable means of detecting decreased ventricular function in myocarditis, even when subclinical. The dysfunction is generally global. Mild impairments in myocardial contractility may be evident only when the study is performed at rest and during exercise. The echocardiogram can also detect coexistent pericardial involvement. Magnetic resonance imaging. Contrast-enhanced MRI, using gadolinium dimeglumin which accumulates in inflammatory lesions, can detect the degree and extent of inflammation. The extent of relative myocardial enhancement correlates with clinical status and left ventricular function. Diagnosis. Acute myocarditis should be suspected whenever a patient, especially a young male, presents with otherwise unexplained cardiac abnormalities of new onset, such as heart failure, arrhythmias, or conduction disturbances. A history of recent upper respiratory infection or enteritis may also be present. A presumptive diagnosis of cardiomyopathy generally requires that congenital, valvular, ischemic, and pulmonary heart disease be ruled out. A presumptive diagnosis of myocarditis may be made on the basis of the clinical and laboratory presentations. This presumption may be strengthened if an echocardiogram is characteristic and does not reveal evidence of other forms of heart disease. A number of other tests have been used in selected cases, but their general utility is relatively limited. Gallium scanning, anti-myosin scans, magnetic resonance imaging. Cardiac catheterization does not yield any specific information but may be valuable in ruling out other cardiac disease, such as congenital or ischemic heart disease. The definitive diagnosis of myocarditis can be made only by endomyocardial biopsy. A negative biopsy does not rule out focal myocarditis because of sampling error. This problem is minimized by multiple biopsies. Endomyocardial biopsy is of greatest value in myocarditis when performed early in the course of the disease. Dallas criteria DX of myocarditis. Introduced in 1986 for DX of pericarditis. Based on endomyocardial biopsy specimens. Active myocarditis, if light microscopy revealed. Infiltrating lymphocytes and myocytolysis. Borderline or ongoing myocarditis if lymphocyte infiltration and no myocytolysis. Negative for myocarditis if no lymphocytic infiltrate and no myocytolysis. Dallas criteria usually underestimates true incidence of myocarditis. Since large inter-observer differences and number of biopsy specimens used. Newer diagnostic methods. Identification of viral genome. In biopsy specimen, histopathologic diagnosis of a specific cause of myocarditis is occasionally possible in patients with toxoplasmosis, Chagas disease, Lyme carditis, and trichinosis. Electron microscopic examination is only rarely contributory, as with the characteristic internuclear or inclusion bodies that may be seen in CMV carditis. Why perform endomyocardial biopsy? Although there is no effective specific therapy for most causes of myocarditis, useful information may be obtained in selected cases of myocarditis. A treatable cause for the myocardial dysfunction will occasionally be identified. For these reasons, in experienced hands, endomyocardial biopsy is of value in the diagnosis and management of myocarditis with a favorable risk-benefit ratio. Natural history. The majority of cases of acute myocarditis have a benign course. In these patients, the inflammatory process is self-limited without clinically overt sequelae. Some patients, however, develop heart failure, serious arrhythmias, disturbances of conduction, or even circulatory collapse. The illness may be fatal due to myocardial failure or sudden, unexpected death. Prognosis. Long-term outcome of patients with biopsy-proved myocarditis, comparison with DSM-JAM Cardiol 1995 July, 26 1, 80-4. 27 patients with myocardial biopsy-proven definite or borderline myocarditis at the Mayo Clinic between 1979 and 1988 were compared with 58 patients with idiopathic DSM who had endomyocardial biopsy findings negative for myocarditis. There was no difference in 5-year survival rate between the myocarditis and DSM groups, 56% versus 54%, respectively. Specific therapy. There are a number of causes, primarily infectious, of myocarditis for which there is specific therapy, such as mycoplasma or Lyme disease. Viral infection is the most common cause of myocarditis, with coccidiovirus B being most frequently implicated. Antiviral therapy with ribavirin or alpha-interferon has been shown to reduce the severity of myocardial lesions as well as mortality in experimental murine myocarditis due to coccidiovirus B3. However, this beneficial effect is seen only if therapy is started prior to inoculation or soon thereafter. The applicability of these findings to humans is therefore uncertain. Nevertheless, antiviral therapy may be considered in acute, fulminant myocarditis, in institutional outbreaks, e.g., in neonates, and in laboratory-acquired cases. Specific therapy. A number of therapeutic trials in humans, mostly uncontrolled, have suggested clinical benefit from immunosuppressive therapy with corticosteroids, azathioprine, or cyclosporine. However, both corticosteroids and cyclosporine have been shown to exacerbate murine myocarditis. The myocarditis treatment trial investigators a clinical trial of immunosuppressive therapy for myocarditis. N. Engel J. Med 1995 August 3 333 5, 269-75. 111 patients with a histopathological diagnosis of myocarditis and a left ventricular ejection fraction of less than 0.45 were randomly assigned to receive conventional therapy alone or combined with a 24-week regimen of immunosuppressive therapy prednisone with either cyclosporine or azathioprine. The mean change in the LV at 28 weeks did not differ significantly between the group of patients who received immunosuppressive therapy and the control group. There was no significant difference in survival between the two groups. The mortality rate for the entire group was 20% at 1 year and 56% at 4.3 years. Non-specific therapy. Avoidance of exercise. Physical activity should be restricted to reduce the work of the heart during the acute phase of myocarditis, especially when there is fever, active systemic infection, or heart failure. Electrocardiographic monitoring. Electrocardiographic monitoring can permit early detection of asymptomatic yet potentially life-threatening arrhythmias and/or conduction defects. Non-specific therapy. Antiarrhythmic drugs. Most antiarrhythmic drugs have negative inotropic activity and may therefore aggravate heart failure. They should therefore be used only when the expected benefit exceeds the risk. Supraventricular arrhythmias may induce or aggravate heart failure. These arrhythmias should be converted. High-grade ventricular ectopy should be treated cautiously with antiarrhythmic drugs. Complete heart block is an indication for transvenous pacing. This conduction abnormality is often transient. As a result, use of a temporary pacemaker should be the first step. Non-specific therapy. Congestive heart failure should be treated with a low-sodium diet and cautiously with digoxin, diuretics, and ACE inhibitors. The threshold for digitalis toxicity may be low. Excessive reduction of preload by diuresis may reduce ventricular filling pressures below the level needed to maintain cardiac output, possibly converting heart failure into cardiogenic shock. Non-specific therapy. Anticoagulation is recommended in patients who fulfill the following criteria. Symptomatic heart failure with ELF below 20%. Minimal risk factors for hemorrhage. A stable hemodynamic profile without evidence of liver synthetic dysfunction. The optimal degree of anticoagulation has not been established. INR between 1.5 and 2.5 is generally recommended.